Hi, I'm Kristen Hayes. I'm a nurse practitioner. I work in a high-risk breast clinic in a comprehensive cancer center at West Cancer Center in Memphis, Tennessee. And I work with the breast surgery clinic in charge of the patients who are at an elevated risk for breast cancer. I've been doing that for about 9 years. And so today we're just going to go over in detail what I do, what kind of patients I see, and what recommendations we have for those patients so that you will be aware and can hopefully be able to identify high-risk patients and help know at least what could be advised for them. So our overall goals today is to develop a basic understanding of risk assessment and clinical management for patients at high risk for breast cancer, be able to integrate this knowledge into practice if applicable, recognize the factors associated with an elevated breast cancer risk, identify patients who are at an elevated risk, and describe the appropriate recommendations for screening and risk reduction, and be familiar with hereditary breast cancer genes. So I'm sure we've probably all heard this number. There's 1 in 8 women in the United States will be diagnosed with breast cancer in their lifetime. And I would guess or assume that probably all of us have at least one friend or family member or colleague that has been diagnosed with breast cancer. So it is very prevalent and very much something that I think we need to focus on how we can lower this risk and how we can catch it early and educate our patients on. This 1 in 8 equates to about a 12% average risk. So just being a woman, no other risk factor is you have about a 12% risk to get breast cancer in your whole lifetime. So the goals of the high risk clinic are to identify these patients who are at high risk, who are above this 12%, and to really develop and tailor personalized screening plans and prevention plans for early detection and risk reduction, so that if these cancers are diagnosed, we can be much more able to treat them easily. They won't be aggressive, and hopefully prevent some of these cancers from ever occurring in the first place. So when we talk about being at risk for breast cancer, some patients come to me and they're confused at why they were flagged as high risk or what factors elevate their risk. And so I think it's important to recognize what goes into these models and what flags patients to be at elevated risk. These factors that we'll go over first are non-modifiable, so things that patients can't change, can't really do anything about, but it's important for them to know what is putting them at that elevated risk. Age, of course, we know that an older age increases most cancer, including breast cancer risk. Probably the most common thing I see patients for in the high-risk clinic are those that have a family history of breast cancer. So having a first-degree relative usually doubles someone's risk. If an average risk is 12%, first-degree relative gets you to about 24%. And then on the same line, if you have an inherited genetic mutation that's been passed down from generation to generation in your bloodline, such as BRCA1, BRCA2, that can affect your breast cancer risk. We know race and ethnicity. African Americans, there's some data showing that they can just be at a greater breast cancer risk in general. There is definitely data showing they're at a higher risk for more aggressive or later diagnosed cancers. There's probably a lot of socioeconomic factors that play into that as well. And then we know Ashkenazi Jewish women, not really in itself increases breast cancer risk, but having that ancestry, you have a much higher risk to have a BRCA1 or a BRCA2 mutation, to those mutations that we talked about before that can increase breast cancer risk. So an average woman has about a 1 in 300 chance of having this mutation. An Ashkenazi Jewish woman has a 1 in 40 chance of having that mutation. So important to know when you're trying to see if someone might qualify for genetic testing. If they're Ashkenazi Jewish, they probably should undergo genetic testing, especially if they have other risk factors. Breast density, that's been a hot topic as of lately that we know increases breast cancer risk. So breast density is seen on a mammogram, and a radiologist categorizes a patient's breast as dense or not dense. If you do have dense breast tissue, we think that there is in and of itself a risk factor of just having dense breast tissue, and cancers are rising in that dense tissue. It can also be a factor because it's harder to see cancers. So patients who have dense breast tissue, these dense tissue shows up as white on mammogram, and so can cancers. So it can be harder to detect cancers within this dense tissue, and maybe they will be found at a later stage versus patients who don't have this dense tissue. If you have a history of chest or mantle radiation, really between the ages of 10 to 30, radiation to this area it increases your breast cancer risk up to about 30% by the time you're 55 years old. If you have a previous breast biopsy showing atypical cells, so ADH, atypical ductal hyperplasia, atypical lobular hyperplasia, lobular carcinoma in situ, those are the three main lesions that are identified on biopsy, and we know they can increase a risk for future breast cancer. Doesn't mean they're going to get a cancer, just increases the risk. Atypia diagnoses or increases breast cancer risk about 1 to 2% per year. That's LCIS. And then atypia about 1% per year. So both of those raises that lifetime risk pretty high. There are gynecological factors. So age at first birth, if you're older than 30 when you have a child, that increases your risk. If you're younger than 30, it lowers your risk. When you start your period matters. So the younger you are, the higher your breast cancer risk is. Same goes with menopause. The older you are that go through menopause, so the longer time you're exposed to hormones in your life, the higher that breast cancer risk is. Whereas women who go through early menopause, it actually lowers their breast cancer risk. Now, those are all things that can't be changed. It's just important to know. But what can a patient actually do to lower their breast cancer risk? We do have some things that we know of that we can advise patients on. And so it's probably things that we are already telling our patients to do to lower most of the disease factors, most risk factors for most diseases and cancers. And these risks are modifiable. So alcohol use, the American Cancer Society recommends less than 1 drink per day. Obesity, we know especially in postmenopausal women, the obesity rate is increased and it does increase breast cancer risk. So advising patients to try to maintain a normal BMI, keep that weight in a healthy range. Hormone replacement therapy. We don't think hormones are all bad. They kind of get a bad rap, and the studies done many years ago, kind of showed that, hey, all hormones cause breast cancer. That's definitely not the case. We do know it's one of the factors that can increase breast cancer risk, but it's very specific to the patient, their age, what kind of hormones they're taking, and things like that. But being on combined estrogen and progesterone is one of the things that can increase someone's breast cancer risk. We really don't see the increased risk as much with just estrogen alone. Physical inactivity going along with the obesity can increase breast cancer or other cancer risks. The American Cancer Society recommends about 150 minutes of physical activity a week. And then no smoking. So these are things, no matter if we're in primary care or another specialty in a high-risk clinic, we can all advise our patients on these, which can lower the risk of breast cancer and many other things as well. So who qualifies as high risk? If they have these things we talked about before, and if they're above 20% lifetime risk. These numbers are found with some risk assessment models that we'll go over in a minute. So usually if you're above that 20%, or if you have any of these factors, it will make someone high risk. If you've had one of those previous biopsies showing atypical cells or LCIS, if you've had radiation therapy to the chest, we can't really include that in these percentage risk models, but we just know it increases your risk. If you have a positive mutation in any of these genes, so BRCA1, BRCA2, TP53, PALB2, CDH1, PTEN, NF1, CHEK2, ATM, STK11, BARD1, RAD51C, and D. All of these germline mutations will make someone high risk for breast cancer. If you have a family history of breast cancer, especially if the lifetime risk is above 20%, some patients will have a family history and, a very distant relative, and so it may not get them above that 20%. But usually if you have a first-degree relative diagnosed at a relatively young age, it would get that number above. And then like we talked about before, the Ashkenazi Jewish ancestry with another risk factor would probably put a patient at high risk. So even if a patient's not high risk, I think it's important to know what factors could put them at elevated risk, and a more detailed assessment should be done if you see a patient that has one of these characteristics. So how do we get those numbers? How do we get to that 20%? We have risk assessment models we use. Mainly in our clinic and my high-risk breast clinic, we use the Tyrer-Cuzick model. That's the one used most frequently. The Gale model is probably the one that's been around the longest and might be heard of by more people who are not in the breast high-risk world. It was originally developed and the first model to be validated to decide on if a patient could qualify for chemoprophylaxis, which is medication to lower their breast cancer risk. And then it was also the first model validated in African-American women. However, it's not the greatest and most accurate risk model because it really only looks at first-degree relatives. and not a lot of paternal family history. So if you have, anybody beyond first degree, then it's not even going to include that. And I really only use the Gale model in practice if a patient doesn't have a family history but has an atypical cell on their biopsy, then I will use it. Otherwise, I use the Tyrer-Cuzick model. Tyrer-Cuzick does overestimate atypia risk, so that's why I use Gale for that. Now, if they have more than one first-degree relative or multiple members in their family or other risk factors such as dense breast tissue, gynecological factors, hormone therapy, things like that, then I use the Tyrer-Cuzick model or the IBIS model. It's the one used most frequently by most high-risk clinics. Most guidelines refer to this. Our imaging mammography center and most mammography centers around where I am use the Tyrer-Cuzick model to determine a patient's risk. It can give a 5-year or a 10-year risk. The 5-year or 10-year risk can determine if a patient qualifies for chemoprophylaxis, which are medications to lower their breast cancer risk. And then the lifetime risk is what's used to calculate if they qualify for extra screening, such as breast MRIs. Both are available and free online and pretty easy to use. It's mainly just data entry. I think I have a picture, yes. So this is what the Tyrer-Cuzick model looks like. You put in all their information, their height, their weight, their gynecological factors. You can put the number of female relatives they have and their ages of diagnosis. The more female relatives you put on there, the more accurate the risk assessment gets. So it is important to have a pretty good pedigree or pretty good family tree of the patient. And then you'll hit calculate risk. Then it gives you their risk. So it'll give you what their 5-year, what their lifetime risk is, and a graph to compare that to what the normal population risk is. And you'll see if that number is above that 20% or not. It'll also give you a risk of this patient having a BRCA mutation. So it could be used to determine if they should get genetic testing if that percentage risk is pretty high. This patient in particular, I think that I put data on, they had already tested negative, so that's why there says 0%. So speaking of the BRCA, the genetic risk, if you're seeing a patient and wondering, should they have genetic testing? Should they be referred to a genetic counselor or genetic specialist? These are some things that should catch your attention and be red flags in a family history that should make us think, is there something hereditary going on here? So really young onset breast cancers, like less than 40s, triple negative breast cancers, especially diagnosed younger than 60. Any male breast cancer should automatically be a red flag to wonder if there is a germline mutation being passed down. If you have multiple affected relatives on the same sides with the same type of cancer, anybody who has a family history of ovarian cancer, we automatically wonder if there's a genetic mutation in play. And then most pancreatic cancers in the family can make us wonder that as well, also bilateral breast cancer. So genetic mutations account for about 10 to 15% of all breast cancers, which means 85% of breast cancers we don't know the cause of. Could be sporadic, environmental, hormone, probably genes we haven't discovered yet, but we do know there is this small sector that are positive for these mutations that we think can contribute to them developing breast cancer. So in our clinic, for patients who have breast cancer, we offer testing to all of those patients who are affected. The American Society of Breast Surgeons updated their guidelines a couple of years ago to recommend genetic testing be offered to anyone with a breast cancer diagnosis. And then as far as the unaffected patients, we still screen them based on their family history. We use the NCCN guidelines to see if they meet criteria for testing and to see if they would meet insurance coverage. So the main criteria we look at, if anyone has a family member diagnosed less than 50 with breast cancer, if they have 3 family members on the same side, no matter first, second, third degree relative, they should qualify for genetics. If they have a first degree relative with pancreatic cancer, any relative, no matter the degree, with ovarian cancer, and then a relative with triple negative breast cancer diagnosed less than 60. So any of these factors should qualify a patient for genetic testing for insurance coverage. The good thing nowadays is that most of the labs, the genetic labs, have self-pay prices that aren't too crazy. Most of them are about $259, $250. So it can still be pricey and expensive, but it is much more affordable than it used to be. And a lot of these labs do have payment plans for patients so they can kind of break out their payments and figure out how to get this covered. This is just a quick graph. Sorry, it's a little small, showing all the genetic mutations. I use this all the time in practice, especially when I have new patients coming in. These are all the breast-related genetic mutations. And so it sort of goes from highest risk to lower risk. BRCA1, BRCA2, TP53, PALB2, CDH1, and PTEN are more of the higher risk, greater than 40% breast cancer risk. And then the other ones below are more of a moderate breast cancer risk. And so based on these mutations, we'll usually recommend extra screening and measures to lower risk. These are some of the newer genes that we found that increase breast cancer risk as well, but not as high as those other ones. So there's about 12 of them in total on the panel that we use with genetic testing that are just related to breast risk. We do know that there is a contralateral breast cancer risk in some of these genetic mutations. In a recent study, the carrier study was done to look at the most common genetic mutations related to breast cancer and what the contralateral breast cancer was. This is important. A lot of times our breast surgeons in our clinic will have a patient come in with a new breast cancer. They are positive for a genetic mutation. And so the surgeon will want to know, well, what's the risk of it coming back in the other breast? And that can help them decide about their treatment, about their surgical plan, and kind of what their management looks like going forward. Most of these showed that in these mutations, there is a increased contralateral breast cancer risk if the patient is diagnosed at premenopausal age. But if they're diagnosed postmenopausal, there's usually not much of a contralateral risk. So now what do we do for these high-risk patients? Most importantly, we have enhanced surveillance. So extra screening, that can be early mammograms, that can be adding breast MRIs, it can be survey breast ultrasounds, CT enhanced mammography in some centers. So if a patient's lifetime risk gets above 20% on those risk models, then they qualify for our high-risk screening protocol. And that's where we recommend doing a mammogram once a year, a breast MRI once a year, and alternating that every 6 months. And so the goal is that we're having some kind of screening every 6 months. We're catching everything at the earliest stage possible. Not really lowering their risk or changing their numbers, but just catching stuff early. MRIs are good because they can find stuff earlier than a mammogram can. They can maybe pick up stuff before a mammogram would see it, and they can also see through that dense breast tissue. So it's another good imaging modality to use for that. There is a new recommendation for patients who've had a breast cancer to undergo mammogram and MRI screening if they were diagnosed less than 50 or if they have dense breast tissue in general. So we are doing a lot more MRIs. If a patient cannot undergo a breast MRI, then at our center, we'll do bilateral ultrasound surveys instead. It's not as good as an MRI, but it's something, and it can look at the breast in addition, kind of be in conjunction with mammogram. There are some centers that are using the contrast enhanced mammography to kind of take the place of these survey ultrasounds as well. If the risk is also less than 20%, but they have dense breast tissue and the patients want to do something extra, want to have more evaluations, then we can talk about adding ultrasound surveys, which are just ultrasounds of both breasts, top to bottom, left to right. And this screening, this high-risk screening, begins when a patient is identified as high risk. So whenever they are above 20%, whenever that risk assessment is done, we usually don't do MRIs less than 25 and no mammograms before 30 in general, unless a patient has a very young family history of breast cancer or based on their genetic mutation, they need to start that screening early. The negative MRI is it does have a higher false positive rate because it's a more sensitive test. It's not as specific, about a 40% false positive rate. So it can create unnecessary biopsies, callbacks, things like that. And it can be expensive. It's generally covered by insurance if patients are above this 20% mark. But if someone has a method deductible, they might have to pay, and it can be pretty pricey. So that's how we catch stuff early. That's the early detection. Now, how do we lower the breast cancer risk? That's where risk-reducing medication or chemoprophylaxis come in. There are 3 different types of these medications. So tamoxifen, raloxifene, which are both SERMs, selective estrogen receptor modulators, and then AIs or aromatase inhibitors. These all are pills, and patients take them once a day, every day for 5 years, and it cuts their breast cancer risk in half. We determine if someone can take these medications, if they qualify for this, by looking at that 5-year risk. So the screening, we look at the lifetime risk, and if it's above 20%, we recommend extra screening. If their 5-year risk is above 1.67, then we can recommend this medication. Alternatively, if you're using a risk model that looks at 10-year risk, if that number is greater than 5%, then we can recommend the medication also. So patients who are premenopausal, tamoxifen is the only one that's been FDA approved for that. Patients who are postmenopausal can take tamoxifen, Avista, or an aromatase inhibitor such as exemestane or anastrozole. Most studies show that 5 years is the time needed to lower that breast cancer risk. There is a new study with baby tamoxifen, we call it, and it's a 5 milligram dose every 3 year for 3 years. That seems to be just as effective, and it has much lower side effect profile. So we have been using that in many of our patients, and it seems to be more tolerated. There are risk versus benefits charts available on NCCN guidelines that we can use for individual patients to see kind of what their risk is of the side effects from these medications and if they would actually benefit for it. The cons to these medications are there are many side effects. So since they are blocking estrogen receptors or lowering estrogen production, a lot of the side effects are menopause related. So it can affect patients' lifestyle and quality of life. And it can be hard to take a medication just to prevent something that can cause more side effects than the patient was even having before. Tamoxifen has a small blood clot risk, as well as raloxifene, about 1 to 2%. So something to be aware of. Tamoxifen also has the uterine cancer risk and cataract, mainly in postmenopausal. AIs have the osteoporosis risks. So it really is a pro and con, risk versus benefit game of who should take these medications and how they're feeling on it. And I always tell patients it's worth trying it. And if they tolerate it and they do fine on it, wonderful. If they don't, then we can go to the next option. Risk-reducing surgery is also an option. Usually in our clinic, surgeons will recommend considering this or think of it as an option for patients if their risk is above that 40% mark. So really would mainly get there if they have an extremely high family history or a genetic mutation or biopsies that increase that risk. We normally recommend trying a medication to lower the risk first, just because it's a much more invasive method that can cut that risk in half. But bilateral prophylactic mastectomy is the most you can do to lower your breast cancer risk, whether you have reconstruction or not. It decreases that risk to about 1 to 2%. So we can never get the risk to zero, but we can get it to 1 to 2%, which is pretty good. After you have a mastectomy, there is no further imaging needed as far as breast cancer screening. All our patients, as we talked about before, we do lifestyle counseling. So talking about eating healthy, getting regular exercise, making sure they have enough sleep at night, no smoking, alcohol, because these are all much easier things to do that each and every patient, no matter what their risk is, can take these into their lifestyle and incorporate them and actually feel like they're doing something to lower their risk. So in summary, early risk identification equals better outcomes for breast cancer. We want to be able to use the validated tools and our clinical judgment for what screening a patient should be doing and what's appropriate for them. Tailored management is essential. Each patient is different, and so it really depends on what their risk factors are to what is appropriate for them. And it is important to keep up to date with guidelines, especially related to genetic mutations, as those are constantly changing. These are my resources. And I think that's all I have for you. If you have any questions, please feel free to reach out to me through email. I'm happy to answer or chat about anything. Thank you.